Thank you to everyone for coming today's Action Hour on climate change effects on public health. We're excited to have you here for this important conversation about how health, climate, and justice intersect and how we can take action to protect our communities. Feel free to leave any questions in the chat. We'll be sure to get to them at the end of the presentation. I'm thrilled to announce our three speakers today. Starting off, we will have Devin Brown, who is the Environmental Justice Manager in the Office of Health Equity at the Connecticut Department of Public Health. His work focuses on advancing environmental justice by addressing how laws and policies shape access to healthy environments, particularly for communities most impacted by health inequities. He centers community expertise in translating research into equitable public health solutions. Next, we will hear from Dr. Kirsten Eck, Assistant Professor of Internal Medicine at Hospitalist at UConn Health. Dr. Eck leads efforts to embed climate and environmental health in medical education and is actively involved in UConn's health sustainable initiatives. She also serves on the board of Connecticut Health Professionals for Climate Action. Finally, we have Hannah Beth, Director of Office of Climate and Health at the Department of Public Health, and she will share her insights from her work managing federal climate health grants and leading strategic planning to align public health priorities with state climate goals. Her background includes over a decade in public health with a focus on the health impacts of climate change. Let me just share my screen and then we will kick it off. Okay, and can everyone see my screen? Okay, perfect.
Right. Fantastic to see you all this almost evening. I'm glad the sun is still out in this season, even though it's still throwing off my internal clock. So good to see you all at 5 p.m. on this day. What will follow with two brilliant speakers after me is a deeper dive into the nitty-gritty of climate science, of health impacts of climate change, and some of the work that the state is doing on the front of climate and health. My presentation will be more of a broad stroke, a more general or conceptual guide through what environmental justice is, and before that, what public health might be, and various forms of the determinants of health. So we'll start really broad in scope, and the two speakers after me will lead us through a deeper dive. And so I'll talk about what the heck public health even is. I find that every year I go home to Thanksgiving, I have to disappoint one more family member in letting them know that I'm not a doctor. So I figure it would be a great time to let everyone know what public health is and maybe what it isn't. I'll define and walk us through a couple of terms that we use a lot, especially in the health equity space of public health, those being social and structural determinants of health. And then I will hopefully make a case for why EJ is pertinent to public health. And then today we won't be getting to cumulative impacts, but another great discussion. Next slide, please. And we won't stay here for very long. So, as someone who has been in the deep end of public health for the greater portion of a decade now, these are a couple of definitions that I absolutely admire and appreciate, and I think speak to both the science and art of what public health is, but I don't think they'll be helpful for us today. But if you leave with one bit of information about public health from this action hour, it's one word, and it's prevention, prevention, prevention. So, next slide, please. Instead of diving into definitions, I'd rather take you through a story. So, if you'll travel with me for a little bit, let's picture that you are with a group of friends having a picnic on the side of a river, and friends are playing good music. We had a successful potluck, which is tough to come by these days, and everyone brought the goods. We're enjoying the picnic, and then suddenly we hear some screaming, we hear some struggling in the river, and there's a child who is drowning. And because we're a group of good Samaritans, we go to the river, we grab the child, the child's okay. They even join us in the picnic until their parents show up. And as we enjoy the rest of the picnic throughout the rest of the day, this keeps happening. More children keep coming down the river. We're having to go into the river and save more and more of these kids. So, because we intuit the public health mindset, we ask two very important questions. How is this happening? And why is this happening? And instead of solely rescuing kids from the river at the source, we decide to go upstream. And what do we find but a bridge that crosses over the river where kids are crossing, but there is no guardrail on the bridge. There's no signs giving a warning about the danger that is ahead. So, our public health solution in asking how do we prevent children from falling into the river in the first place, we say, let's put up a guardrail, let's put up some signs, because while it's important to save the kiddos from the river, we'd be doing even better to prevent them from falling in the first place. And that's how I like to break down public health for my family members and others that don't have much of a frame of reference for what the work might include. Next slide, please. And to tap even more into the existing frame of reference that folks have, I like to do a one-to-one to medicine, since my family members do think I got an ND over the last 2 years. And so instead of like doctors treating one patient, in public health, our patients are entire neighborhoods, entire communities, entire populations. And while a doctor or a healthcare provider will do a great job of providing that care when the patient shows up to the doctor's office, public health's job is to be treating these patients, these neighborhoods, these communities before they ever get sick. How we might do this, well, on the medical side, we might see prescriptions, treatments, and surgeries. Public health, we're interested in educating the public about public health hazards. Maybe that's lead in your homes, maybe that's radon, maybe it's the hazards of extreme heat. Sometimes it's laws and regulations. How can we make the world around us safer by default so that folks aren't getting sick or getting hurt? That can be something as simple, wasn't always simple, as mandating seatbelts in cars or outlawing smoking on an airplane. Two big wins for public health through the legal route. And then, of course, we have public health programs, which largely link folks to healthcare services or other health enabling resources that I'll break down a little bit later with our social determinants. So, at the crux of it, while medicine might be dealing with the healing and curing of patients, on the public health side, we really want to prevent illness and injury from occurring in the first place. And what you can see on the right is the variety of ways that public health might do this. Next slide, please. So I'll break down two terms, and these two terms being foundational to my interest and love for public health. That I accidentally stumbled upon public health in college in looking to get an easy A and took my first public health course. Heard about social determinants and said, "Whoa, I don't think it's medicine that I want to do. I think it's caring for entire populations." Next slide, please. And so when we break down the determinants of health for entire communities, for entire populations, we can crudely break them into these categories: genes and biology, physical environment, clinical care, health behaviors, and social and economic factors. And what we can see, or what's clear to us on the public health side, is that genes and biology, for the most case, is not modifiable. And so we look to the other 90% of the pie to understand where public health might be able to intervene in protecting the health of the public. And what you'll see in there also is that clinical care or interactions with the healthcare system, getting your prescription, seeing the doctor, also only make up about 10% of the determinants of health. So in public health, while a lot of our work is focused on increasing healthcare access and quality, a lot of our attention is focused at the 80%, which we lump up into the social determinants of health. And so when we think about something like health equity, we consider these social determinants of health as determinants of people's ability to access good health, not just healthcare. Next, please. Nice. And so we won't dive into all of this, but just wanted to break down an understanding of social determinants as the conditions in which people are born, where they live, where they learn, where they work, the context in which an individual and a community's health develops. So we're thinking about access to education, we're thinking about economic stability, we're thinking about social and community context, the neighborhood and built environment, and of course, healthcare access and quality. So some examples are going to be safe housing, transportation in neighborhoods, whether you have access to nutritious foods or physical activity opportunities in your neighborhood. And then, of course, pertinent to our conversation today, is there polluted air or water where you live, where you work, where you play? Next slide, please. And then, even a little more esoteric, are what we call the structural determinants of health. But to make this the most simple, we understand the structural determinants as the factors that influence how social determinants like education, healthcare, economic resources, the built environment, how they're distributed differently at the local level. What role do policies, social norms, and how a government operates, what role do they play in determining for instance, which environmental benefits and which environmental burdens go to which communities, and at what scale? Next slide. So then I was brought to the Connecticut Department of Public Health just last June, almost a year in the position, but it feels like maybe 4.5 days. I'm brand new to state government and it's a circus in its own right, but having a joy of a time. But I was hired to identify and develop the scope of work for environmental justice at the Department of Public Health. And so I'll break down how the department looks to define environmental justice, and then I'll break down how the work looks at a very broad level for us. So next slide, looking to give some clean language for what EJ might be. And I very much appreciate the definition that the American Public Health Association uses, that begins environmental justice with the idea that all people and communities have the right to live and thrive in safe and healthy environments. And if you ask what this looks like, it's split into three goals. We've got the equitable distribution of environmental benefits and burdens. We've got the equal protection under public health and environmental law. And then most importantly, especially to the historic movement that environmental justice is the meaningful involvement of affected communities in those decisions that affect their environments, that affect their public health. And when we think about who this applies to, I had to spend a lot of time thinking about this in the context of the Department of Public Health, because on one end, we have an entire branch of the department that is focused on environmental exposures. And then we also have an office, which I work in, that is focused on improving health outcomes for the most sensitive populations, or those communities, those neighborhoods that already have existing health and social inequities. But what you have at that overlap are the communities that are the most vulnerable. They're not only the communities with the greatest concentration of environmental hazards, and maybe the least concentration of environmental benefits, but they're also those with the greatest sensitivities, the greatest health and social sensitivities that not only make them more vulnerable to the worst adverse health outcomes of climate change and environmental hazards, but they also make it more difficult to recover and more difficult to prevent in the first place. Next slide. And to close out, just to frame our work a little bit more, environmental justice at DPH is an extension of the work that we do in the Office of Health Equity, but specific to the environment. And we, following the example that the last federal administration set, we look to broaden the environment not just to the natural environment, to air, water, and soil, but also thinking about the built environment, the building, the places that we live, transportation routes, where we have access to green space in our neighborhoods, our access to safe drinking water, but also the social environment, violence and prevalence of injury at the local level, laws, regulations, policies at the local level, and how these all interact to influence health outcomes at a population scope. And so, three overarching activities for environmental justice are to find where those environmental inequities are. Where do greater concentrations of environmental hazards exist with social and health sensitivities? Working to understand why those inequities exist and understand communities' barriers to environmental justice, and then he is working alongside those affected communities to not only identify and prioritize these inequities, but to work with them to eliminate these barriers. And so I'll be handing off to the brilliant Dr. Kirsten Elk, who will walk us through what some manifestations of adverse health outcomes from extreme climate events may look like, health effects from a changing climate may look like. And important to keep in mind that those EJ communities that I discussed in this portion of the presentation are also those that will face the brunt of the worst health outcomes in the face of a changing climate. So off to you, Dr. Elk. Dr. Eck.
Heck, yes. Hi. Devin, I have to tell you, I have an MD. I did go to med school, but for every one doctor, there need to be at least 10 public health people. And then I could go out of business. I would retire. Never was that more clear to me during COVID when we were taking care of really sick people in the hospital and looking out, and it was you guys really getting a handle on this whole pandemic that we've just come through, and we need more of you. So thank you for everything you do.
Certainly a team effort.
Yeah. Am I sharing? Am I
Yes.
sharing my screen?
Yes.
Am I? I don't see it. This is the problem. What do you see on
We
on
see,
your
oh,
side?
we have your presentation up.
Okay, interesting. I don't see it. Anybody have advice for me? Share. Sorry, one
We
moment.
still see your PowerPoint view. So I don't know, you might have gone into presentation mode and it went to a different screen. Did that happen?
Oh, you know what? You're right. Ah,
Nice.
okay, let me see. What do you see now?
Still the same.
Do you
Now we're
see,
full screen. Now we're good to go.
okay, do you see a flooded street?
Sure
Yes.
do.
Okay, all right, great. So I'm Kirsten Eck. I'm one of the hospitalist doctors up at UConn Health. I want to just tell you about two patients that I took care of. I'll start with a gentleman who came into the hospital. He was a resident of North Hartford. Um, and that, as Devin was saying, is one of our environmental justice communities who have been underserved by updated sewer storm drains, along with other communities around Connecticut who just didn't get that luxury. So every time these extreme weather events happen, this gentleman's basement floods, and it floods with dirty water, and it sits in there. And it happens often enough that it's expensive to hire a Serve Pro. And so he had been trying to clean it up for his family himself. And he was exposed to a lot of mold down there, and it kicked up his asthma. And his asthma got worse. His breathing was worse and worse. He was short of breath. His chest was tight. And his family made him come into the hospital when he actually started coughing up blood. Um, and it was a very good thing that they did, because what he had was um, this mold that had gotten, this fungus had gotten deep into his lungs. And when it gets in there, it can start to invade the blood vessels of the lungs. And it is quite a high mortality condition. He ended up in the ICU. He did survive. Um, but some people who have this don't make it. And he had a long hospital stay. It was expensive. He couldn't work for a number of months around the time of the illness and after. Another patient came into the hospital. He had gone to the beach. This is a picture of Hammonasset. And he had diabetes. And as many people with diabetes may have, he had wounds on both his feet, small wounds, and he wasn't even necessarily aware of them. But he went wading to cool off in the summer in kind of brackish water in one of the shallower areas. And he presented to the hospital not too long after, and I'm sorry for this photo if it's off-putting, with rapidly ascending infection going up both legs, from his feet all the way up, extending up toward his upper thighs. And it happened, progressed very quickly with high fevers. He looked quite ill. He also ended up in the ICU. with this infection. And the cause was Vibrio vulnificans, which is a bacteria that thrives in warm waters. And we anticipate we may see more and more of these type of infections. And there are a number of infections that thrive in warmth in a heating planet. But this one has a high mortality rate and has to be acted upon very quickly. And he also survived, but it was a very long hospital stay as well, and expensive. And he had some permanent damage from this to his legs. But the interesting thing is that for neither of these people did their discharge summaries from the hospital make that connection to extreme weather and to a heating planet at all. It's silent. You would just see a diagnosis of Vibrio and a cellulitis of the legs, or a fungal infection of the lungs if you looked at his diagnoses. But you wouldn't see that this was made much more likely and will continue to be more likely due to a heating planet. The other thing to note is that storms that are happening, these extreme weather events that are happening all over the place with increasing intensity and frequency, actually have impacted maybe some people you know here in Connecticut. And this was Hurricane Helene. It really hit North Carolina, if you recall, in September. And how it impacted UConn Health is that the Baxter IV fluid plant, which makes, I think, something like 60% of the nation's IV fluid bags that we use to treat very, very ill patients, such as the gentleman I just talked about, critical IV fluids, was down. And we got warnings that look like this, and this is an actual screenshot, that there are significant shortage of IV fluids. Please employ conservation strategies. And we got these emails like, this is critical, we're running out. So this really impacted how well we could care for patients. And again, although I guess we knew about this plant, it's hard for us. We're as a profession terrible at making that connection to what's going on with a heating planet and how this will impact people's health and also disrupt healthcare delivery. So I just point that out because it's something that we could do better as a group. But when I think about you all sitting here listening to this, I like to consider what we're doing. I'm sitting at my desk. You all are maybe sitting somewhere, and we are a collection of organs. And they're pretty good organs. Like, they're pretty finely tuned. They're doing their job. We don't really pay much attention probably. But they are attuned to work at a very specific temperature range. And when that range gets out of whack, they don't work so well. So if you consider like the egg in your breakfast, when you cook it, there's a set temperature where that egg goes from looking like an egg to looking like scrambled eggs. The proteins in it denature, that's albumin proteins. We have the same proteins, and things will go wrong if we exceed on either side the temperature range at which we evolved to work in. So if we turn up the heat, if you all go to your thermostat and crank up the heat to 100 in your house and sit here and listen to this, very quickly, you will begin either consciously or subconsciously to take actions to keep yourself in that comfort range that we evolved in. You might fan yourself, you might take sips of water, you might take layers off, but you will do things to keep yourself in the temperature range. And when we think about what set temperature this begins to go wrong, we know already what that is. And this is a core body temperature measured rectally with a thermometer, a core body temperature of 104 degrees Fahrenheit. And if you start to have confusion, delirium, you start to become less conscious, sort of altered, that you meet the definition for heat stroke. And that is a true emergency. You don't have very many minutes to get that under control and reversed, or all kinds of things go wrong. And as we know, the heat impacts people even at lower temperatures, especially people who are pregnant. Fetuses don't really like, they don't do well in hot temperatures. They can't regulate. And this happens very, very quickly. If you sit here and just flex your arm muscle back and forth, like, curl your bicep, about 20% of that energy that you're using makes that muscle move. The other 80 is actually expended as heat, and we have to eliminate heat all the time from our body in order to function well. So what happens if you add external temperature that gets hotter and hotter, and even worse if you add humidity? Because the only other way we can cool is to sweat some of that heat that we're producing inside. And we actually, well, I should say we thought we knew what that was, the theoretical limit of heat tolerance for humans. And this is not a straight temperature of 95 degrees Fahrenheit. It's called a wet bulb globe temperature because it also takes into account that critical humidity, which is, if there's too much humidity, we just can't sweat and eliminate that heat that we make. So you can arrive at this wet bulb globe temperature of 95 in a variety of very unpleasant conditions. Any combination like 103 outside with 75% humidity, that will get you there. Any kind of unpleasant combination. And this was what scientists believed to be the limit. If you sit in that wet bulb globe, however you get there, for 6 hours, that's it pretty much. But, and I put a but here because I find this very worrisome. This is a study from Penn State, and they have an amazing heat research lab. And they put some very healthy young volunteers, something like 18 to 34-year-olds, healthy people, into heat tanks, and they swallow sensors and crank up the heat. And this is a study I would never in a million years sign up for, but anyway, these people do. And it made them realize they take them as far as they can when they start to see that they've reached the limit. And now for healthy people, the wet bulb globe temperature is 31 degrees Celsius. It's been revised downward. So we are less tolerant than scientists have thought humans were. And again, you can arrive at that wet bulb globe at a variety of unpleasant conditions, such as 87 degrees Fahrenheit with 100% humidity. But this down revised tolerance limit, that doesn't include for older people, for people with medical conditions, for certain medications that they're on that make it harder for them to sweat, make them more vulnerable to heat. So this is for your healthy, young, fit people. And if I take you to Chicago in 1995, it's a little bit of a busy graph, but if you're looking on the orange line, this is the usual number of people who died, like every day, the average number of deaths in Chicago in that around that summer of 1995. And on the green line, you see the temperatures that was June, late June, and then you hit July, around July 11th, say, and there was this sharp heat wave. So the temperature really spiked up to 106. But that, you gotta think about that wet bulb globe thing, that the humidity made it feels like temperature of 125. And within a very short time, the number of daily deaths spiked tremendously. 700 people just felled. And majority of them were older or had medical vulnerabilities. And I have a picture of looks like the Grim Reaper, but it meant to have it be a farm worker, because we know that farm workers are very, very exposed to heat and die at 20 times the rate of other workers, other professions. So it's not only older people who are affected by these heat waves. But I just want to go back to Chicago in 1995 and call out something. At no point in this heat wave did the wet bulb globe temperature exceed 28 degrees Celsius. So that's quite below that 31 heat tank. And yet you can see it felled a number of people. And to some extent, you could argue that Chicago, those folks aren't heat adapted, but nor are we really in Connecticut. So I don't think it's a surprise to anybody on this call. You've all, I'm sure, heard this, that 2024 was the hottest year on record. And this is just going back from the pre-industrial era. On the left here, this is the rising temperature. We're now about 1.2, 1.3 degrees Celsius above our pre-industrial temperatures. And we know exactly, I mean, this is not a mystery to anyone. We have been digging up old carbon that's been sequestered from the ground, every old dinosaur that's down there, every old tree leaf that's turned into fossil fuels, and we've dug it up and rapidly added it up into our atmosphere over that time period. So I'd like to ask you to think, maybe one of you know this, but what is the level of CO2, one of our main greenhouse gases, today actually yesterday. I looked it up yesterday. What is it in our atmosphere in parts per million, ppm? So in Hawaii, they are tracking that, and the website was still active as of yesterday, May 19th, and we are up to 430. So this slide is a little older now. We are up to 430 parts per million. The average for April was about 429 parts per million. And I see this as a white knuckle moment. Like, I look at this is humanity's white knuckle moment, because there's very good evidence going back way beyond this slide to out to 2 million, and some would estimate even 3 million, but very high confidence that for 2 million years, it's not been this high. And the thing is, we humans evolved in this mid 200s range, some ups and downs, but we've managed to make a living on this planet over that time period, and our organs evolved over that time period. We are well above this now, and we aren't feeling the effects of that, not the full brunt of that yet. So I'd just like to take a minute, and I'm sorry if I insult this audience because I know you're very sophisticated, but I had to get a handle on what these greenhouse gases were and what they were doing to how are they, when we perturb them, how are they affecting our health? This is a slide from NASA. All you got to know, sun coming in, solar radiation coming in, the Earth's surface absorbs it and sends it back up as infrared. But we have these greenhouse gases, miraculously, this exact composition of greenhouse gases that send the right amount, just the right amount back to us so we live comfortably here for 2-3 million or more years. So what happens when you start to pile up greenhouse gases? And what are those greenhouse gases why are they so bad? Or I should say, not bad, but why is it an issue when we perturb this beautiful, delicate balance? So I looked up, exactly what CO2 is our big one. And basically compared to other gases like oxygen or nitrogen, which are widely in our atmosphere, CO2 has a more complex vibration mode. Again, this is highly simplified, but it worked for me to understand. And, they jiggle a little better, and they trap the radiation that's coming up from the Earth better, more potently, more powerfully, and send it kind of back down, send that heat back down to us. We know that CO2 is the biggest one up there. It's doing a very good job of trapping heat for us. Methane, when you hear natural gas, that's methane, is 80 times more efficient at passing the radiation that's coming up and sending the heat back down, 80 times more than CO2. So when we talk about expanding natural gas in Connecticut, we're talking about adding something even more potent than the big dog, carbon dioxide. When we look at F gases, and this is where I have a lot of professional guilt, some of the propellants, like for example, your albuterol inhaler for asthma, this is a F gas type, and it's very, very potent. Desflurane, if you've ever had anesthesia, it goes right through you, and it's right out to the atmosphere, and it's 1,000 times more potent than CO2, which is already potent in its own right. But that's not all. It's not all just how effective, oops. Sorry, what is this? It's coming in slowly. Sorry. It's also how long it sits up there, the half-life that we have to consider. So carbon dioxide, it has a long half-life, 120 years for the first half, and then another 120 for the next half of it, and then another 120. And so 300,000 years, the CO2 that we burned in our tailpipe car, if you drove a gas car today, you emitted about 404 grams. That will sit up there at a half-life of 120 years, and it will still be there. Your contribution today, 300, even longer, up to 1,000 years, today's contribution that we throw up into the atmosphere. Methane, thankfully, I guess, has a shorter half-life, but remember, it's 80 times more potent. And these F gases, some of them stay up there much, much longer and are very toxic to the atmosphere. So when you put those two concepts together, how well it jiggles and traps heat, and how long it stays up there, CO2 is potent, methane all the more. And then you look at some of the anesthetics and other hydrofluorocarbons, they're 2,000 to 12,000 times more potent. And they set a future temperature dial that we don't feel yet. So this is, I promise I'll be done with this section, but this one really gets to me. because I asked myself, well, okay, so if I double the amount of carbon dioxide, remember we were evolving as humans in the 280s maybe of parts per million carbon dioxide. So what if you double that? You chum the atmosphere with double the amount. What happens? Like, how hot will that make it? And this is a concept that, I don't know, keeps me awake at night thinking about. But there are scientists much smarter than me who map this. They model, these are climate models. So this is 40 CMIP6 models. These are all around the world. These are climate modeling teams. They build their climate models, very complex, and then they chum it. They add double the CO2 and they run them and see what happens. What temperature increase do these models predict? And basically, you can see all these different models, and there's some sort of midway. And if we double it, it's very likely that the temperature increase will be 2 to 5 degrees Celsius. I don't really speak Celsius. It doesn't mean that much to me. The best guess is about 3 degrees Celsius or 5.4 degrees Fahrenheit. That works for me. So more than 5 degrees hotter. But those were 2020 models. And as I read a little more, the models are running, some of them are running hotter than that. So, I don't know exactly. I'm not sure how to wrap my head around that. Are they getting better? Are they getting more accurate? We don't know. But some of them worrisomely are predicting hotter sensitivity. So let's go back to this graph. And I'd like you to stake out in your mind if you're an optimist or a pessimist here. Just take a moment and tell me. Right now, let's see, when they made this slide, it was around 400. Now we're at 430. So where do you see these parts per million CO2 topping off by the year 2100, end of this century, 75 years from now? Do you see it topping off maybe here, 500? Do you see it topping off way off the charts, 1,000 by the year 2100? So you guys, pessimists, you're up here. Pick a number, and then follow me to the next slide. So these are different scenarios. These are warming scenarios, and they're for the year 2100, just what you just did in your mind. So you pessimists who predicted high numbers, go sit on this line, please, and stay there and don't come out. Stay there. You're predicting over 1,000. So think about what you're saying. By the end of this century, you're looking at well over 1,000 parts per million. And you optimists, I really like you. You predicted we'd stay down in 490, somewhere under 500. And in your mind, we as a globe are taking aggressive greenhouse gas reduction efforts. Maybe the rest of you are sort of moderates in between. Yeah, somewhere. I don't know with you guys, but let's focus on the optimists and pessimists here and follow me to the next line, because what I want to know is, if you're a pessimist, how hot is it going to get? If we follow your drill, baby, drill, dig up every last sequestered carbon and throw it up into the atmosphere pathway, what are you saying? So again, these depend on what climate sensitivity, what models you use, but roughly you pessimists are putting us at 5 to 10 degrees hotter on average by the year 2100. And you optimists, you're keeping it lower. Thank you for that. So follow me to the national weather heat index. You've probably all seen this on TV on hot days. So where were you pessimists? So you're saying 5 to 10 degrees hotter. So the pessimists, let's say we had a 98-degree day. We had some hot 90-degree days. And so you're going to bump on average the summer days out by something like 10 degrees. So way out here. And you just need a little humidity, and you're very rapidly in the extreme danger. And make no mistake, you saw the heat tank data. Like, this is extremely dangerous for any amount of time. You can't function, you can't live. So pessimist, I don't know about you. But that's the drill, baby, drill pathway. So when the United Nations Intergovernmental Panel on Climate Change projected the global impact, now this depends on your scenario. So here's your optimists and these are your pessimists out here. This was projected days per year where that combo of heat and humidity pose a risk of death. And you can see that out here, It is many, many days per year. These are days per year. So Russians and Canadians, they're looking pretty good in many of these scenarios. Days per year were of risk of dying from hyperthermia, high temperature. But if you look out here in the pessimist pathway, in some places, it will not be habitable for many days of the year. It will not be compatible with human life. And the thing is, this data, these maps were made before those findings of the new heat tank research, which lowered our understanding of what humans can actually tolerate. So there are some estimates of 50 to 75% of the population may be exposed to incompatible with life temperatures. And overall, the IPCC estimates that 3.3 to 3.6 billion people live in contexts highly vulnerable to climate. So talk about a justice issue. Those temperature projections, this is on average, but that doesn't include your hottest day. Go back to Chicago in 1995 where you had those 2 really, really hot days. Those are called hottest day anomalies, the hottest day of the year. Those will be even hotter. So these are projections this is in Celsius, 7 degrees Celsius, your hottest days. Okay. And depending on which pathway we follow. So that's about 12.6 Fahrenheit, your hottest day. So bump up your hottest day of last summer by at least 12 degrees. So to me, this is profoundly worrying. And we're not even going to get into this, but these are your tipping points, thresholds at which once you cross, they're irreversible. And I put this here because these, again, scientists are trying to estimate when these happen. And if you look at the bottom, the thresholds, 2 degrees, this is you're more toward the optimist side, but you get into the pessimist scenarios here. And you see, once these things happen, these are the thresholds where they are predicted right now, as best case we know, to happen. They're irreversible on a human timescale. So where are we headed? Now, this slide was made by the Climate Analytics and New Climate Institute. They do this every year. They update it. I'm sorry, I got you the November one. This is before the election and before we pulled out of Paris Agreement as a nation. But when we were all on board, and many, many nations were on board, I think all but like 4 or 5 countries were not, and started making, okay, I'll do this, making agreements, and we were on track. So let me back up. So here's the temperature increase by 2100, the pathway we're following. And Paris Agreement was to keep us no hotter than 1.5 degrees Celsius on average above our usual pre-industrial baseline. That was our agreement, many nations working toward it. So with all the policies and actions in place before the election around the world, the estimate was that we were heading somewhere around 3 degrees Celsius. So just keep in mind these thresholds and where we're going. So 3 degrees by 2100. I don't know what to say now that I don't know where we're headed, but I don't want to leave you on a terrible note. So there's reason for hope. And DEEP, Connecticut DEEP mapped out our emissions by sector. We know what our Connecticut sector emissions are and who's, what we really need to tackle. I think we're really lucky to live in this state with legislators who are really forward thinking and really care about this and know their stuff. And so very lofty goals were set, even while some states are not setting them. And we actually met our 2020 goal to reduce Connecticut's greenhouse emissions by 10% compared to our 1990 levels. We did it. And then COVID came and we all stayed home. And we were doing really well. We were on track to meet our 2030 goals to reduce by 45% from 2001. And then we started backsliding. And we are currently not on track to meet our 2050 goal. Not at all. We're backsliding. But the good news is that Yale did this opinion mapping. They do great opinion mapping. And they surveyed Connecticut. Regardless of your political affiliation, the majority of people in Connecticut want change. They want our legislators, they want us to tackle this. And I find this slide really, really hopeful, at least for Connecticut as a state. And I have two bills here. Just these are really hopeful bills that should tackle this. I just love to read these and thank our legislators. But just stepping back and thinking about Connecticut and all the labor and delivery units around Connecticut today that are babies were born today, and trying to imagine what kind of heat burden they will face as they age, totally depends on what we do. I mean, in part as a state, as a nation, as a globe, what their heat scenario. So your pessimistic scenario up here, you can see what a huge heat burden these children today will bear as they age. And I highlighted 2100 because the thing is, these temperatures, we're setting a future preheat dial with these emissions sitting up there. And I don't think anyone in this call is fooled that this ends at 2100. The temperature burden will continue to increase decade upon decade upon decade. So those babies, their children, their grandchildren are the ones facing down that cliff beyond that graph. And to me, going back to what Devin was saying, this is a profound environmental injustice, profound injustice to them. And I think I just feel very grateful to be on this call with people like yourselves who really care enough to come on a Tuesday night and hear this and take action, and for everyone on this call for all you do, because we've got to tackle this. And so I'll turn it over to Hannah. Thank you so much. And how do I get out of it? Let's see, stop sharing. Sorry, Hannah.
That's okay.
Am I out? Am I out?
Yeah, I think so.
Okay, I'm sorry, Hannah.
That's okay. Lily, is that you sharing?
Yes, this is me.
Okay, perfect. Can you see me on camera? I can't see myself.
Yes.
Okay, perfect. That's fine. All right, so I know we are a little tight on time, so I'm going to try to go quickly through here, but happy to take questions or talk with folks offline if you want. So we'll go to the next slide, please. And very broadly, I want to build on what Devin and Kirsten were saying and talking about some of the things we're doing in the state to address the health impacts of climate change. So there's two roles that I'm going to discuss really quickly. The first, next slide, thank you, is public health as a convener. So it's really for a long time, public health has been seen as a sort of facilitator of resources. And in that vein, we're focusing on three different actions. So building a coalition of people who really care about the intersection of public health and climate change. Bridge building within the agency by combining our resources to tackle sort of cross-cutting climate initiatives. And focusing on providing support and technical assistance to local health departments who are already or who would like to be engaging in climate resiliency actions at the municipal level. Next slide, please. And I'll start with quickly explaining our Climate and Health Equity Coalition. That's the coalition I mentioned in the slide back. So this is a group that formed under our foundational climate grant funding that I'll explain a little bit more about in a few minutes. And the purpose and the goals are outlined here, but essentially they advise the monitoring, the evaluation, the implementation, and the dissemination of all of our activities under a grant called BRACE. Next slide, please. And members are coming from a lot of different backgrounds, some of which are recognized here. So pulling from different state agencies, pulling from local health departments, lots of different nonprofit and academic organizations are represented as well. And this brings a lot of depth and breadth to our conversations that we have on the coalition. Next slide, please. And this is an open ask to say that we meet for about 90 minutes quarterly, and I've included some examples of what we use the meetings for. That includes sort of technical and strategic advice on the development of different project plans. Sometimes we ask members to review work that we've done and provide feedback in the meeting. And we also sort of lob different ideas of how to build off of projects that we've already started planning. et cetera, just to help them round out and be a little bit better. So notably, this is a public meeting. If you're interested in it, you can join us just as a listener through the CGA website or through the link here on the slide. And if you're interested in becoming a member, as I said, this is an open sort of welcome to anyone who would like to join us, and you can drop me a line later. Next slide, please. So moving quickly through bridge building, these are the things we're focusing on doing internally here at DPH. So building capacity for more climate action, increasing education and policy focused work, communicating more effectively about climate change and health, and ensuring that all of our actions are evidence-based. So some examples of what we do that aren't associated with our grant work that I'll turn to shortly are providing, for example, expertise on regulations that need to be adapted to integrate climate considerations, providing trainings to local health departments and districts at their request, and building bridges between other DPH programs and my office so that we can ensure that we have all the sort of applicable data that we need to inform our priority actions. Next slide, please. And lastly, a key sort of tenet of our work is providing specific offerings to local health departments and districts, and we're hoping to build as the office grows, sort of in the later section to offer more of those services and continue to increase the number of climate activities and resiliency measures that are occurring at the local level. So under the now heading, those are things that we're offering now, like supporting with grant applications, providing expertise, developing trainings, as I mentioned, and what we're building towards is doing more sort of intentional, impactful work like impact assessments and providing technical support, keeping a running list of grant opportunities, developing a suite of trainings that people can sort of plug and play, sharing communication content, doing data analysis for local health departments, those kinds of things. But I'll note that the Office of Climate and Health at DPH right now is just me, so I'm a bit limited in what we can do, but that's sort of building out our future vision. Next slide, please. And the second big role we have as an agency is around adaptation. So Kirsten talked a lot about mitigation, the causes of climate change, and now I want to introduce the term adaptation because when we talk about climate actions or resiliency measures or anything like that, that really all falls under the adaptation umbrella. So as was previously mentioned, mitigation is the act of actually reducing those greenhouse gas emissions, as I think you all know. We know that this is the single most effective way to decrease climate change. However, it is very difficult, a lot of that political will coming in. And it's also not in DPH purview. So Kirsten mentioned DEEP had done a lot of these things, and that's true. What we think is in DPH's purview is our adaptation activities, and that's how we prepare for and reduce in this context, the health impacts associated with climate change. So we're talking about altering exposure pathways, reducing sensitivity, and increasing community capacity to adjust to climate change. So moving along to our adaptation activities. Next slide, please. I want to introduce our BRACE grant that some of you may have heard of. This is a CDC grant that we were awarded in 2021. We're currently in year 4 of 5 of that grant, and I took over in 2024 in overseeing the implementation and administration of it. It stands for Building Resilience Against Climate Effects. And the grant objectives are pretty broad, as you can see. These are the objectives as they were outlined in the NOVO. And the first is to leverage the BRACE grant funding to develop an Office of Climate and Health at DPH. Yeah, we'll keep moving right along. So getting into the next slide, these are our 2 adaptation actions that we're obligated to administer under the BRACE grant. The first action is led by us here at DPH, and that's to develop and implement an educational program for local health departments to reduce resident exposure to the health effects of climate change. And the second adaptation action, we have contracted with the Yale Center on Climate Change and Health to develop guidance for local heat and air quality response plans, which include alerts and communication strategies, and they support local implementation through trainings, capacity building, and sort of working one-on-one, providing technical assistance to a few local health departments. So I'm going to skip through the curriculum overview pretty quickly. Things to note here is that that we released a survey that was sent to all 59 health departments, as it said here. That sort of informs the basis of our curriculum. So I'm going to ask Lily to skip through the survey results. And I believe you'll get these slides, but we'll stop here at curriculum breakdown. So after analyzing all of the data that we received in the survey, this is what we were left with. We had local health departments rank the climate hazards and health impacts they were most concerned about, and it's probably not surprising to anyone here, but those are reflected here as extreme weather, temperature, namely heat, air quality, namely ozone and PM 2.5, water and foodborne illnesses, and vector-borne illnesses. And the next slide shows the module format, which I'm also going to skip through just in the interest of time. And so I want to highlight quickly other BRACE activities. We developed a climate impact compendium, which hosts a sort of culmination of different resources and things for people if you are looking for any climate research papers. Really, it should be updated, but there is an existing resource on the DPH website for that. Skipping ahead, I will highlight also the Climate and Health Equity Symposium. Our first one occurred in March of last year. We had another one planned for March of this year. Obviously, you all know what has been happening since around the late January, so we've postponed that for now, and we have it tentatively scheduled for September, and we're hoping to move forward with that, whether it's virtual or not. And then I'm going to skip ahead a few slides, Lily, if you don't mind, to go to the local heat and air quality planning template slide, so the next one. And I just want to call attention here to the template that was developed with the Yale Center on Climate Change and Health and some students and some input from local health departments as well. I have a link I can drop in the slide. This is an available resource to anybody who's working sort of at the municipal level. It's a downloadable template that you can sort of plug in and play. There's also infographics and additional resources on that website. So what we'll be doing is working with a few local health departments to do some of that planning process. And then I'm going to skip all the way down to our equity and justice slide. And I'll just pause here to say these are our sort of priority areas at DPH. These are the sort of things that we're going to be focusing on moving forward. So as you might have picked up, the BRACE grant focuses really on extreme heat and air quality. We're hoping to bring in some more work on extreme weather and vectors as we move forward. And of course, all of that work is still centered in equity and addressing the structural impacts that Devin was talking about as well. So when we talk about climate change as a risk amplifier, what we really mean is that those who have already been made vulnerable to health disparities because of those existing social or structural inequities will be made more vulnerable by climate change. So that's the sort of foundation of the work we're doing, and then we're building on the climate hazards work from there. So if you are interested in being involved or just want to talk more about what we're doing at DPH, the final slide has my email. And I will wrap up there. Thank you so much for having us.
Thank you all for this. I want to say thank you to the speakers for being here, like Kirsten said, on a Tuesday night. Let me see if there's any. I don't see any questions in the chat. I'll give it 30 seconds or a minute or so for people if they have any questions. But if not, again, this will be up on our YouTube. I will also be sending a follow-up email with the slides that will also be published on our website. So, and with any questions, you can contact me or anyone else. Seeing no questions, I just want to say thank you guys. And yeah, I hope you guys have a good evening.
Thank you
Thanks.
all.
Good night.
Bye.